Courtney Aiken. And Courtney, I understand, has recently married. And so there is is Aiken your new name or your?
Is my new name.
Okay, so I have that right. So Courtney is with Nebraska Medicine across the street. She's a nutritionalist, and she's another example of someone where I listened to her presentation, and I thought, this is really good stuff. And I contacted her to see if she would be interested in presenting. And here she is. So help me in welcoming Courtney.
Awesome. I think I'm unmuted. Okay, cool.
You can advance by going right here.
Great, perfect. I'm kind of loud at baseline, so I'll try not to blow the ears off of everybody here and on Zoom. But yep, my name is Courtney Aiken. So I'm a registered dietitian. I have most of my background through the outpatient setting. So I work in primary care, see a little bit of everything, but if I had to sum it up in like what I saw big bulks of, probably would be weight management and diabetes management. Super glad I was able to hear the last bit of that panel, because it sounds like we're talking lots of like advocacy, growth, and things like that in your positions. And so I think this will be really useful. The main thing I like to point out is, you have one patient, but you have an army of people on their care team. So you guys are one of them, I am one of them, there's so many others, and we can work together. So just kind of bringing awareness to my role that could be with the patient, and how we can kind of connect that way. So today we're talking mostly about diabetes. Oops, sorry, I'll try to not do that again. Mainly talking diabetes. It's very broad, very generalized, but just some kind of tidbits that might be helpful in terms of kind of getting them information quicker, and kind of giving you guys the resources of how you could connect them to a dietitian if you felt that that was appropriate. I have no disclosures, no conflicts of interest. Kind of just to give you an idea of what I plan to talk about today is what I do, what my role is in the team. As I mentioned, you also play a very vital role. And then we're going to just kind of talk about the different stages of diabetes and some recommendations that might be beneficial. Sounds like counseling is an area as well that you guys might be growing in as well. So just touching on some things that I would kind of really want someone to know like right away, or just kind of some things to prepare you guys for that patient might be feeling or questioning, so you feel a little bit more equipped to answer those questions. So we'll talk diabetes prevention, mainly those patients in the pre-diabetic stage. Then the nutrition recommendations for diabetes, both type 1 and type 2, they do differ kind of what we focus on in my role. And then some nutrition considerations on the medication side of things, both, taking them appropriately, some side effects that could be something to watch out for on the nutrition side when they're taking them, things like that. Some non-diet related reasons that someone might be on diabetes medication to help mitigate hyperglycemia. And then a conclusion questions area. I mean, nutrition's huge. It's so broad. There's so many people out there talking about it. And so I'd be happy to clarify any sort of topic or question that you might have in the nutrition world. Doesn't necessarily have to be diabetes related, but certainly could be. So what is a registered dietitian? Might lose you guys a little bit here because it's a little bit confusing. There's a lot of different letters that essentially mean the same thing, just a little bit of a variation. So for my name, I have Courtney Aiken, RD. That RD stands for Registered Dietitian. You may also see RDN, Registered Dietitian Nutritionist. It's kind of like a what do you prefer kind of vibe. It's not necessarily one or the other. It kind of depends on states. Could also depend on countries, just kind of what was, kind of like the spelling of dietitian, is it with a T or a C? They're kind of both correct, it just depends on what part of the world you're kind of talking about. And then difference from RD to like RN, for example, for registered nurses. Right now you get your RN and you can practice kind of wherever you want to go. If you move to California, you get a job as an RN. You move to Delaware, you get a job as an RN. For an RD, a lot of states require specific state licensures. So for me, I'm licensed in Nebraska and Iowa. So I also have LMNT, Licensed Medical Nutrition Therapist, which is saying I can practice on patients in the state of Nebraska. And then I have LD, which is Iowa, just licensed dietitian. That's just how it goes by. So if I were you and you were like, oh, is this person like a credible dietitian? Have they gone through the same standards? If you see RD or RDN, those are the same thing. But one really important distinction that I want everyone to really take away from this is that every dietitian can claim that they're a nutritionist, but not all nutritionists can claim that they're a dietitian. They are different. Kind of how this graphic outlines the different educational backgrounds and qualifications, how there are quite a bit for dietitians and then not really any for nutritionists, and so on. So just a little bit of backstory there. Required to get a bachelor's degree with very specific nutrition courses, then required to complete a certain amount of supervised practice hours, then required to get their master's degree. A nutritionist could technically graduate high school, or I suppose not even if they didn't want to, and then just say that they've done research on their own and they're a nutritionist. So it's that stark of a difference. Now, a lot of these nutritionists aren't going to do that. They're going to get some certifications. They're going to take some classes. They're going to have, some sort of background. But just to kind of clarify how stark of a difference it could be and how important it is to know the distinction between the two. Access to RD services. This is definitely where y'all will come in quite a bit. According to the Commission on Dietetic Registration, though that's basically the national committee that gave me my RD after I sat for my exam. Oh yeah, they have to have an exam too. Forgot that part. Once I sat for that and passed that, this is the place that basically said, yep, here you go, here's your RD, you are now a registered dietitian. As of April 1st of this year, they said there are 112,683 registered dietitians. That's then compared to over 1 million physicians. Then when you think of all the doctors out there, right, and how many patients they have on their workload, that's a lot of people, like patients, to dietitians that are available. So the access right now especially is very limited. It's a growing field, very similar to what it sounds like you guys are experiencing as well. Tons of room for growth and expansion of services. RDs are feeling that as well, and really trying to fight for feeling valued in the care system and the role that we play and how important each of our roles are. We're in the same boat as you guys, it sounds like, so that's really great. There's also a lot of barriers that you find in RD, but there's cost. So insurance coverage, maybe they have insurance, maybe they don't, depends on the insurance how much it will cover. You're talking lack of transportation as well. So there are a lot of places in the nation where there's not a dietitian located for over 25 miles. So yes, you have telemedicine. That's a forever growing field. I don't think that's going anywhere, which is great. But that doesn't mean everyone has those resources either. You have to have internet and the webcam, and you have to have health, you have to have the literacy to know how to manage that. So still quite a big barrier when there's not a close proximity of patient to dietitian. But some community spaces. So sounds like in this room we've got like inpatient, outpatient kind of vibes. You can do both. Same as dietitians. They have private practices as well. Insurance would be the biggest barrier there for private practices, but I know there is a major one in Omaha. So just kind of quick little Google search, I suppose, would kind of help you determine if there's one in your area. Inpatient or outpatient, as I said. Hy-Vee has recently re-expanded their services. So I know there was quite a good, yay, here we go, growing Hy-Vee dietitians. And then COVID hit, and that took a lot out of that company. Prior to COVID, they were doing food demonstrations. They have a really nice demo kitchen. They were doing those. They were taking patients around the store, helping them grocery shop, maybe after they had a stroke and they're discharged from the hospital and they're like, you need a heart-healthy diet. And someone's like, what does that mean for my groceries, right? The dietitians at Hy-Vee can do that and kind of really paint that picture, like make that actual connection with them, which is really awesome. Sometimes they even run like free A1C checks or free vitamin this checks. And so just kind of staying up to date with that. And that seems to be really kind of coming back full force, which is great. And then some schools, you could see some dietitians working on staff schools talking like school lunch program and making sure people have, or the students, I should say, have the balanced meals that they're required to have from the state, kind of being a part of that legislature. But I mean, that being said, if food's involved, the dietitian can probably have a job in there. So you have dietitians tucked away everywhere. Yeah, you got inpatient, you got outpatient, you got like the healthcare clinical setting, But you've also got, like state legislature, you've got people working in food safety, dairy council, meat council, just kind of all over the place. So even that 112,000 people that I mentioned earlier, that's not assuming all of them are practicing like medical nutrition therapy or doing any sort of nutrition counseling on a like patient to provider face-to-face basis. So huge barrier there, we're working on it. So what do I do? Roles of an RD, it differs, right? But I'm gonna be kind of speaking on more so from a role of a dietitian who speaks medical nutrition therapy or does like the counseling. So pretty much goes assessment, identify the problem, education, intervention, and then goal setting. It's going to look different on an inpatient to outpatient basis, but that's the general flow of how meeting with patients and appointments go. We can manage acute and chronic disease states. Feel like you'll see a lot more of the acute on the inpatient side of things. But I mean, people present to the hospital with pre-existing chronic conditions, right? So they do a little bit of both as well. But I do a lot of chronic things that aren't necessarily going to go away, that they just have to learn to adapt with and make adjustments for moving forward. Provide guidance on different diet restrictions, whether that's, again, they had a stroke or they were diagnosed with high blood pressure and they're saying heart-healthy diet, low-sodium diet, helping them manage that. Allergies or intolerances, like IBS kind of situations. Celiac's really kind of grown. People are really starting to identify that more. And it can be triggered throughout someone's lifespan. So maybe they're 45 and now they have celiac and they're told they have to completely abstain from gluten. And they haven't had to do that for the last 45 years. So that's quite a big transition. That's another place where we really have the time to sit down and discuss it. Whereas, physicians are kind of like, in and out a lot of times. They're super busy. We really have that time to iron out with the patient. We manage nutrition support, so TPN through veins or enteral nutrition where we're using the gut. Typically in my role, if they're doing nutrition support, it's enteral nutrition. It's probably like a G-tube or a GJ or something like that. It's more long-term, And then education is a huge part of my job, specifically the role that nutrition plays in conjunction with different medications. Whether that's as a side effect, whether it's you need to take this with food or you need to wait to eat until you've taken this for 30 minutes, really ironing out, making sure they're getting what they need from their medication and they don't know that they're accidentally hindering absorption. You've got carbidopa, levodopa, right? We talk protein a lot with that for Parkinson's disease, all the things. So we'll start with pre-diabetes, kind of like the diabetes prevention side of things. Right now that's defined as an A1C of 5.7 to 6.4. So what I really, really would love for everyone who might see a patient in this space to understand is this diagnosis is often associated with very high levels of fear. People feel shameful, they feel guilty, they feel maybe they made direct choices that put them here, and they're terrified to be told they have type 2 diabetes. It's a scary thing, for sure, for a lot of people. So they're usually quite motivated at this time to kind of make some changes or modifications or something of the sort to prevent the onset. Not always, sometimes they don't understand. They're like, oh, pre-diabetes, that's, nothing. I'm not diabetic or anything. Education comes in there too, but for the most part, they're pretty much like, you even said diabetes, I want no part of that. Medication at this stage is not always all that common. I feel that it totally depends on the provider, totally depends on the physician. If they have a strong medical history or, if there's maybe lifestyle or diet modifications that aren't doable for some reason or not appropriate, then maybe we'll start some metformin, but usually people want to take like the whole diet modification step first before initiating the medication. Weight loss is generally recommended at this stage, though I want to kind of really tiptoe around this because not always. Potentially, sure, but just because someone's diagnosed with prediabetes or diabetes, that does not automatically mean, well, you need to lose weight. So be careful with that, if that's something that comes up. But what we've seen statistically is if people do lose 5 to 7% of their body weight, that can have a really positive effect on their hemoglobin A1C. But again, that doesn't mean that it's appropriate for every person stepping into your office. Some nutrition focuses, some big hard hitters that I'll be like the first to kind of pinpoint, if you will, would be sugar-containing beverages. Are you drinking any? That's usually the first easiest area to kind of scale back. Maybe they don't know, right? A lot of this comes from stemming from just not knowing, health literacy or just not understanding the connection. So maybe they're drinking soda or juice or milk or something like that, and like quite a bit throughout the day. That would be the first area I'm like, listen, let's just kind of scale that back and see if that can't help some things. We'll talk incorporation of more whole grain carbohydrates, or I guess like better carbs, more blood sugar stability-esque carbs. And we'll talk of physical activity. Again, not always necessarily for the outcome of weight loss, but it can help improve organ function, cardiovascular health, to just be physically active, even if it doesn't result in weight loss. I love to remind the patients at this point, like, this is a really good place to catch it. We have time to go back. I try to put a positive spin on it. As I mentioned, coming in with lots of negativity, lots of disappointment, lots of fear. So really trying to spin that of like we have time, we can do this, we can do that. We can bring it back to, where we don't even have to have this discussion anymore. Let's just take it one day at a time. So type 1 and type 2, there is some differences in nutrition therapy here. Boy, are carbs kind of like the enemy, right, when talking about diabetes. So I think I talk about this in a bit, but that's the last thing that I want to do, is instill any sort of fear in these people that they cannot have carbs or should not have carbs. Sometimes they come to me already initiating a no-carb or low-carb diet. Again, all with the benefit of trying to control things. But sometimes that's not always most appropriate for people. We'll talk about that in a bit. For type 1 in particular, there is usually quite an emphasis on carb counting. This might be an area you all are very familiar with, because type 1 diabetics usually utilize insulin. They'll mealtime dose based on how many carbs they're having. They'll shoot it to the pump will take care of it, right? So, giving them that education of making sure they understand how to count their carbs, what that means, how to enter that in the system, la-di-da-di-da. Main goal there is to maintain blood stability. We don't want any sort of highs, we don't want lows, obviously, something stable in between. And it's just more of a chronic thing, we're really just making sure that they're safe with the insulin. If they don't understand how to properly count carbs, they could misdose their insulin. Yikes, let's not do that. So that's kind of the vibe there. For type 2, we're talking really only counting carbs on like a broad spectrum, like not to a T. That's assuming they're not dosing insulin. They could be. Type 2 diabetics take insulin, but not all of them. Most of them try to avoid it if they can. Maybe they'll start with it if their A1C is kind of spooky high, but then the goal would be to wean off of that insulin and, treat with something easier, like oral or just a once weekly injection, something like that. So carb counting for them might look more just like addressing portion sizes, aiming to have carbs about 1/4 of the plate. Kind of could be like 1/2 cup to a cup is what I say a lot for like rice and pasta. Don't worry about your sandwiches. If you're gonna have a sandwich, have 2 slices of bread. Like, it's gonna be okay. But just kind of getting them to understand, like, but if you have the bread, like maybe you typically have fries with it, that would also be a carbohydrate. Let's try to keep it to just smaller portions and keep it consistent. For type 2 diabetics, weight loss also might be something of discussion, but once again, not always. I cannot stress that enough, so hopefully you're getting the gist of what I'm trying to put out there, but it definitely might be, usually very patient-led. If that's something that they're interested in seeking, then we can explore that. Diabetes and fad diets. I talk a lot about diets in my role. I get a lot of questions about it. And if any of you have questions about certain ones, totally more than happy to answer them. I totally get it. I've outlined just a few here that are more, I guess, brought up often, like more frequent, and have more of an effect on someone with diabetes in terms of it might not just not be a great idea for sustainability, but it might be dangerous. So the first one's intermittent fasting, which I guess I assumed everyone knows what this means. So what this means is they go a certain period of time without eating intentionally. So Some people might try to go 16 hours without eating and allow themselves 8 hours of eating. Did I do that math right? Hopefully. Okay, thank you. That's one. 12, whatever the other number is, I'm not doing that math. But anyway, so they'll have like very specific boundaries of like, I'm not going to eat past 6, and then I'm not going to eat my breakfast until 10 or 11 a.m. Okay. For some folks, that really does work in terms of weight loss, more specifically. But there is some concern for hypoglycemia there, low blood sugars. What's their medication regimen? I mean, how are you supposed to take a long-acting insulin even in the morning and then not eat it until 2 p.m.? Like, that doesn't sound very safe. Or just the interactions with different medications they might be taking outside of diabetes. The success that people see typically with intermittent fasting is just a calorie reduction. Like if they're seeing weight loss from intermittent fasting, they're just eating less. Maybe they do snack at night and they said, nope, I'm not eating past 6 p.m. Well, that's 400, 500 calories of a snack they're not having anymore. It's not like there's these different things that come in your body and eat away at your stores. You're just eating less calories. So we can do that in different ways. We can still eat consistently, keep blood sugars nice and stable, really help that medication regimen work well and be consistent without having to tell ourselves we have to skip certain meals just to lose weight or improve things. Keto, I'm assuming everyone's heard that one, but in case you haven't, it's kind of depends on the person, how they define it. It's very relative. It's one of the first questions I ask patients when they come in and they're like, I'm on keto. I'm like, what does that mean to you? Because I've heard just about 20 different versions of it. Overall goal is very, very low to no carbs. Main focus is going to be on protein and fats. Okay, yeah, we talk high protein diet, but my main concern there would be hypoglycemia. If they're being told by a doctor, inpatient or out, working with the pharmacy team, then they're like, here's this medication regimen that we've ironed out for you, and they say, okay, sounds good, and they go home and they're like, boy, I'm scared. I'm going to start the keto diet because I don't want this high blood sugar thing to happen. This is spooky. Well, they just cut the carbs. Their care team doesn't know that, and they're still taking medications, assuming that the patient's still eating the carbs. They don't understand that connection. So again, it's all coming from a place of, I just want to better my health. I just want to improve things. So being very careful is not be like, oh, that's a terrible idea. Just be like, oh, tell me about that. What drew you to that? What are kind of your thoughts? Oh, I just want to get my blood sugars under control. Here's another way we could do it, maybe. A little bit softer than just, no, bad idea, dangerous. My main concern too is sustainability. Okay, so people will do it for a couple months. They'll see really good success. They'll lose weight. Their blood sugars are better. All their labs are better. They're like, this is amazing. Oh my gosh, this is great. 3, 4, 5 months pass, and they're like, man, there's a lot of graduation parties coming up. This sucks. Oh, my daughter's getting married. I can't have any of the cake that is never going to be here again for the rest of my life because this is just their wedding cake. And they haven't practiced how to be mindful in those spaces and how to have little bits of that food and enjoy themselves when it's appropriate and how to have that as part of a balanced diet. And so then they just kind of lose a little bit of control. And they have a rough day, and then that reflects on the next day being like, I totally did bad and, I'm done with it. Kind of losing all motivation for any sort of diet changes because they failed. They feel it's a direct failure and it's representation of something they didn't do well. So just trying to avoid all of that. That sounds horrible, doesn't it? Who wants that cycle? That sounds so totally terrible. So trying to just let them know, here are our concerns, but support them at the same time. Paleo, not as common. I feel like this was common when I was an undergrad. It's better, I suppose. The idea is essentially you eat a diet that cavemen kind of would eat. So food that's around without having to necessarily like hunter-gatherer times. So it does open options for more fruits and veggies and things like that, which a dietitian's always gonna love. But there's still concern for that sustainability and having consistent carbs. If they're identifying, processed carbs like breads and things like that as a no-go, where are you getting your carbs from? Are you having a whole bunch of fruit at this meal and then none at this? And, just sustainability or consistency is an issue. My goals regarding changes to the diet and any sort of diet changes. These are fad diets for a reason. I don't want them to fear carbs. It's natural, it's normal, it's spooky. Diabetes is a really, really scary, scary word for a lot of folks. But I really try to prevent that fear from growing and festering, because that can kind of start this cycle of never ending trying new things, and they don't work, and then you try something else and then it doesn't work, and it's just really, really stressful for a long period of time. And avoiding, of course, any sort of negative consequences long term. We don't know what some of those might be for some of these diets, so that's the main concern. Things like vitamin mineral deficiencies, damage to metabolism, and overall that poor relationship with food that I've kind of outlined, that cycle mentality, diet cycles that a lot of people find themselves in, and I'm sure really would love to get themselves out. But once it's been something that you've dealt with for a while, it's hard to break. It takes time. It can be done. That's intuitive eating, a whole nother lecture. So a great place for you guys, people are going to ask you questions. Especially if, you're growing in this space and you're really putting yourselves in positions to be asked these questions, which is fabulous, then where can you kind of point them in the right direction? Say you're like, okay, no RDs are local, or I don't really know how to make that happen. Let them know we exist maybe, but maybe that's to the extent of what you can do. A step further would be providing them a list of reputable resources. So the American Diabetes Association, always great. They've got information on all things diabetes, carb counting, medication discussions, supplements, we'll talk about those in a bit, recipe ideas, exercise recommendations. I'm like you name it, it's there. It's just a vault, and it's reputable. Again, enforcing reputable things, Mayo Clinic, Nebraska Medicine, things like that. Really major research hospitals or academic hospitals are great places to turn them to as well. Same with that Hy-Vee dietitian. There are select locations right now growing. I see tons of colleagues just being like, I've accepted this position. I'm like, this is great. That was such an awesome community resource that I was really missing. So just being like, hey, do you shop at Hy-Vee? You have questions about your groceries? See if your local one has a dietitian. I know some travel too. So, if one may be housed here, but maybe they're going to be somewhere else next week. I don't know. So those are some places you could kind of turn them to. Supplements for diabetes. This is always fun. There's a ton, by the way, of things that people just like, I heard this does that, and I want to take that, and I'm sure you guys hear it. You work around that space. You are more the, prescription, actual reputable conversation, but it's probably housed in the same area, especially if you're talking like an outpatient setting. When you're looking for weight gain to help increase protein, so this is usually someone who's experiencing unintentional weight loss, or someone who maybe is undergoing some sort of treatment, is very sick, something like that. Glucerna, may have heard of it, is essentially like a meal replacement type shake, focused on being blood sugar safe and kind of taking into consideration not being too high sugar or too high carbs, but still has those calories, some protein, things like that in there to help them either regain their weight or prevent that weight loss from continuing. Premier Protein, that's everywhere. Oh boy, is that everywhere, which is great. Again, another really great one. Mainly just protein, so 30 grams right out the gate, lots of great flavors. I recommend that one a lot. Other options or gain is plant-based. So if someone has like milk allergies or something like that, or that's a preference of theirs, then that's a really good option. It's pretty much Premier Protein, but plant-based. And then Fairlife Core Power, also one that you might have, it's just blowing up all over social media. They're making protein ice cream out of it, and they're Ninja Creamies. I'm like, okay, sounds good to me. So those are really good ones. That's actually probably the best tasting one on the market right now. So if someone's like, I hate protein shakes, I can't get over that taste, Fairlife Core Power, that's a good brand to kind of turn them towards. Typically found in like Walmart, you can get them individually, Costco and Sam's Club, really big packs. And they're cheaper there too. Vitamins and minerals. So general rule of thumb, this goes for every disease state or any point of life, any phase of life. If you're deficient, you get your labs drawn and your vitamin D is tanked because you live in Nebraska. I don't know how many of you actually live here, but your vitamin D is tanked, or your B12 is tanked or something like that, then it's perfectly appropriate to take a supplement to help bring you back up to being sufficient in that vitamin. But what I want people to be careful of is sometimes there's this rhetoric online, and I realize who I'm talking to. So I'm sure some of this is like, yeah, we know. But in the patient side of it, there's a lot of rhetoric out there that's like, take this to help this, and it's some sort of vitamin and mineral supplement. But if you're not deficient, you might be paying for something that your kidneys are just excreting out because you have plenty of it anyway, burning your money on fire or literally flushing it down the toilet. Or, worse, it could reach some sort of level of toxicity that is actually quite dangerous to organ function or just overall health. So they do recommend getting certain labs checked: vitamin B12, vitamin D, chromium. This is from the ADA website. Niacin is sometimes taken for HDL, but can cause an increase in fasting blood sugar levels. So if that's something they're like, why is this happening? Like, I don't know, are you taking niacin? Or if they hear that that's a great thing to take, it's just kind of like, well, there could be consequences and a different facet of things. At the end of the day, you have what you need. You don't need to supplement it. Like, your body will hold on to it. If you are deficient, supplementation is fine. We aim to get as many of your vitamins and minerals as you can from your food, but that's quite a tall ask sometimes, for sure.
You have a question
Yeah.
on the supplements. What about Boost?
Yeah, that's a good one. They don't necessarily take blood sugars into consideration. Sometimes the question, I don't know if people can hear. Yeah, the question is, what about Boost? That's another very common one. Or Ensure. Boost and Ensure, like pretty much the same thing, different names. The thought would be, it's not going to be as low in sugar or carbs as like Glucerna, but if someone's losing weight rapidly or worse, already malnourished, there's a risk reward there, right? They're withering away, or they take a little bit of extra insulin, or something like that. So especially if that's the only option, Boost or Ensure, and they're dropping weight like crazy, or they need something, great. They can't find Glucerna, whatever. That's not what's covered by their insurance, something like that. Something's always going to be better than nothing. Glucerna would just be preferable. Okay. Other supplements, more homeopathic kind of style, people have, some people are like, okay, I see I have high blood sugar. I'm going to do everything I can in my diet because I'd prefer to not take medication. Just so everyone's on the same page as like what dietitians think when it comes to pharmaceuticals and the role in medication management, we are very much, they work together. And we'll talk a little bit about that later in the presentation as well. Yes, you're going to have certain dietitians, I'm sure, who specialize in doing all that they can to prevent someone from needing to take medication. Dietitians in general are not against medication at all. Like at all. So we very much so do work together in that space. And in fact, that's here to debunk some things that maybe people are like, just do this and it will lower your blood sugar. And it's like, well, maybe not enough to keep it safe. It's just not safe to have that high of an A1C. So cinnamon's one of them. You might have heard. People were saying, cinnamon helps to really decrease the blood sugar in your body and it helps keep things stable and blah, blah, blah. There's really no long-term evidence of that. It is not comparable to something like metformin or other diabetes drugs. So if you were to have an elevated A1C and take cinnamon, like cinnamon tablets or something like that, we're not likely to see the same outcome. And if you're teetering with like a 10 A1C already, like let's just not think we can eat enough cinnamon. Like that's kind of the big gist there too. It has other health benefits, like it's a part of a healthy diet, other things in there that would be great. So that's totally fine if you want to cook with it or make more of a point to cook with it. Can't hurt, right? But when you're comparing it to other things that will be more beneficial to your health, it's not comparable at all. Berberine, sometimes I look around to see if anyone's like, well, yeah, I've heard about that, but y'all aren't giving me much. Berberine, there's some short-term evidence. It's relatively new. It's essentially a berry. They process in whatever way they say that they want to. Maybe they make it into a powder or whatever, throw it in a tablet and tell you to take the tablet. There's some short-term evidence that it does have blood sugar lowering effects. But right now, research is indicating that it works best in conjunction with some other diabetes meds, such as metformin, and not recommended as a sole treatment. It's also reported to result in some weight loss, which is also desirable, as I mentioned, for some folks in this population, and can have some potential cholesterol-lowering effects. We'll talk about this a little bit, but when it comes to nutrition research, you can't necessarily isolate one thing ever. So it's really important to say, okay, well, if they lost weight and their cholesterol went down, did those two things happen because they made different, better choices to their diet, or was it the berberine? So overall, just kind of being careful with those things. Before I move on, I suppose, to the different medications and side effects and things like that that we look at on the dietitian side of things. FDA regulations for supplements. They're not always FDA regulated. So I have that conversation with patients a lot too, where say it's a greens tablet. Those are really popular too. Or even a greens powder. For the most part, your life isn't going to change if you take one of those things. Your labs aren't going to magically go perfect. You're not going to drop 5 pounds. That's not going to happen. It does potentially have like a little bit of that placebo effect though. People get up in the morning and they take their green juice or they take their tablet and they feel good about it. It gets them a tall glass of water in the morning maybe first thing. Sounds good to me. And it gets them on the right track for the rest of the day. So I'm careful not to be like, don't do that. It's a waste of your time, a waste of your money. Because if it gets you in that mindset and you feel good, then great. Like I have no problem with that. But I will caution that you might not be getting what you're paying for necessarily. That's part of it not being FDA regulated. I'm not worried there's rat poison in there. Like I'm not like, oh my gosh, you're just gonna, fall over. But if it says there's 500 milligrams of chlorophyll, for example, there might not be any. They did a recent kind of pull off the shelf for, I think it was a greens supplement. I don't know if it was a powder or a tablet, but they tested it and they were like, yeah, there's like half the stuff that it's claiming is in there is not in there at all. It's just a lot of the cheapest of the blend, right? So they can make more of a profit. So again, not likely to hurt you, also not likely to make a huge benefit to your health by itself, but if it helps you kind of get the ball rolling on things and you feel good about it and you have the means, right, the financial aid to do that, then great, like more power to you. I just want to take away the idea that some folks have that they feel like they have to have those things in order to see positive changes. Nutrition and medication. So I am not a doctor. I am not a pharmacist. I'm not a pharmacy technician. I am none of the sort. But we work really, really closely. If you were to actually see how the hierarchy in terms of management is in my role, the top tier person manages both nutrition and pharmacy departments because we're so intertwined. Just to kind of see, like, I'm hopeful that as your roles grow and my roles grow, we work more closely together than maybe we currently do. But just kind of going into when I talk a little bit about medications here, I don't have the knowledge that you guys do on medications. I just know some nutritional things to kind of keep in mind. So you might already know all of these things. Definition of hypoglycemia, a dangerously low blood sugar is typically defined as less than 70 milligrams per deciliter, but I think Nebraska medicine standards, for example, kind of push that to 80. 80 to 180 is kind of where they like to hang out, just for safety reasons. Signs and symptoms, we do a little bit of emphasis education on signs and symptoms of hypoglycemia, so you know what they're looking out for, and then we talk about how to treat it. So the 15-15 rule for treatment, that is directly off the American Diabetes Association website as well. Essentially, you have a low, you treat with 15 grams of carbs, you wait 15 minutes, you check again. If you're not going up, you do the same thing again. 15 grams of carbs, wait another 15 minutes and check. Usually that's best if it's like a 4-ounce juice box or a glucose tab or two. It's usually the main thing that I say, hey, keep some juice boxes in your fridge at home, keep some glucose tabs in your purse or in your car. Unless you live in a very hot place, then this room's kind of toasty. I see some people fanning. I'm like, woo! I feel like I'm getting my workout in this morning. Afternoon, what time is it? You don't necessarily want to treat with a slow release carb. So that's something that I really talk people through. Like we say sugar, we're basically treating with sugar. So like, okay, pop a hard candy in. Well, you have to suck on that for a while before that hits your system. We're talking something you can down. Glucose tabs, as you probably know, are like Tums. They just chew them up real quick, like easy peasy done. That's what we're looking for. Nothing that's going to take a lot of time to really hit the system for a low. Those who are at increased risk for having hypoglycemia issues, if you're on insulin, there's a huge margin of error there for folks, especially if it's like type 2 diabetes. They're not used to anything like this. Type 1, you're typically born with it or find very, very early in your life, and so you've grown up with it. Type 2 patients, not the case. So insulin is still kind of like am I doing this right? Which they don't understand how dangerous that could be. We obviously do. Sulfonylureas, I'm not even going to run through the names of the other three because I'm sure I'll make a fool of myself, but we watch out for extra hypoglycemic risk there just based on how they're made up. Typically, it's not an issue. I haven't had that as an issue. Pharmacy and physicians, that's their, they know what they're doing to iron out a regimen that's safe. But if I do see something like that, I might make it a point to really be like, no lows, right? How often, when, if that correlates with when they take it, those kinds of things. Alcohol use, so you get intoxicated because your liver can't metabolize, or your body in general can't metabolize alcohol. That also kind of affects insulin secretion in the body as well. So people are at increased risk for hypoglycemic events when they're drinking alcohol. Usually the standards are still the same, 1 drink for women, 2 drinks for men on a daily basis. If you exceed any of those recommendations, you're putting yourself at risk for a hypoglycemic event. And then obviously those who don't really feel the low blood sugars, they are out there. For the most part, people feel them, but some really don't. And that's kind of spooky. They might have their CGM going off and they're like, oh wow, I'm 75. And they're like, I feel fine. So that's kind of like, ooh, we're going to keep that CGM attached. Yes, we will. Weight loss, decreased appetite. So interestingly enough, obviously this is focused on diabetes. I could probably give the same kind of talk around weight loss medications. That's certainly grown. I'm sure you guys have seen a lot more of that. Oh yeah, that was great, yeah. So there's a little bit of overlap between diabetes meds and the weight loss meds. And so weight loss and decreased appetite, again, not always desirable. So just because that's an outcome, that doesn't make it a good thing. So we watch out for those things. Let's see. Specifically, the injections, which again, I'm sure you're all very familiar, can help or cause, depending on the side that you're on of this situation, early satiety, which basically means that you feel like full, like really full for a really long period of time. Your portions are going to be way small. Maybe you have no desire. If you push past that, you could actually get sick or feel really, really, really sick. So again, for the weight loss side of things, that's helpful. But on the flip side of things, if you're not trying to lose weight or weight loss isn't healthy, then maybe we're looking at some malnutrition, and we have to kind of do some things in the diet to combat the fact that you don't feel hungry, you feel full sooner so that you're not losing so much weight. Usually in the form of high calorie, high protein food choices, extra drizzles of olive oil on your veggies, high fat dairy for the time being. Again, a risk reward, right? High fat dairy is kind of coming back into being like, oh, well, there's actually a lot of health benefits to, how nutrition is, right? Smaller, more frequent meals, so that early satiety side of things, like you're not feeling like you're at capacity about to spill over so much, you're just having smaller amounts, kind of keeping it full, but like giving it time to come down and then filling it back up, time to come down, filling it back up kind of thing. And then the supplements like the Glucerna, that'd be a good thing to add in here too. So medications where I see this most often, metformin is mainly just a decrease in appetite and honestly quite a bit of altered GI function or diarrhea. Super common. I usually ask, like, how are you tolerating that, especially if they're kind of titrating those doses up as they get used to it. I want them to know that that's normal. That can be spooky too, right? Making sure hydration status is up to par if that is the case, if it's a little bit a lot, and just making sure that that either subsides over time, gets controlled, those kinds of things. But most of the weekly injections, like Ozempic, things like that, nausea can be common at the start of getting it done. And then as time passes, the side effects might subside until it's time for the new dose. But this is generally where we're going to see the most weight loss because it has much more of an effect on the GI in terms of early satiety, lack of appetite, and nausea. Reasons you might have a high blood sugar that's not diet related. As I mentioned way in the beginning, folks come into the clinic that I work at. I wish, maybe one day, right? But they'll come in and they'll be like, okay, I'm going to talk to a dietitian. Already kind of spooked about that. We have a pretty rough stigma that we're kind of like this, or that our diets are perfect, which doesn't exist. But that's scary. That's a very vulnerable thing to talk about your diet. And they're feeling guilty because a lot of people feel like the choices that they made are a direct relationship to the outcome of their diagnosis, which is not always the case. So I just wanted to bring to light some other reasons someone might be having high blood sugars. It might be coming to me or coming to you for medications that have nothing to do with their diet, and they could eat a perfect diet that, again, doesn't exist. But they could be and still have high blood sugars. So acute issues such as steroid-induced hyperglycemia, that's cancer treatment, status post-transplant. So a lot of people who are getting organ transplants actually have a diabetes educator who has to sign off on them before they're discharged because they're about to be discharged on insulin because they're gonna have such high blood sugars. Pretty normal. Burns, other really high stress situations like that could cause hyperglycemia. Again, not diet related, like you didn't make that choice. Age, just with an overall decreased function in organs. If you had a Whipple surgery, and genetics. How I handle the genetic side of things, like genetic predisposition, I get that question a lot too. I have a strong family history of diabetes. How do I know that I could do everything right and it's still going to result in diabetes because of my family history? What I say is you don't know that. It might. You might still have diabetes in your future because of how strong your genetic predisposition is. But how much worse would it be if you didn't take care of it from what you could control, is kind of the conversation that I have. So now you're talking the difference between insulin and metformin. A pill in the morning and a pill at night, or 2 pills in the morning and 2 pills at night, or dosing yourself with insulin. I didn't do it. Or maybe I did, I don't really know. Or dosing yourself with insulin several times a day, constantly carb counting, making sure you're doing everything right, that could be a really high stress situation. So I just try to bring perspective, validate that yes, this is something that can play a role. That is not something that is an excuse. That's valid. But everything that you can control, every choice that you can make, can prevent that from being so out of control that it is further damaging to organs, your longevity, overall other health outcomes. That's how I kind of navigate that. So at the end of the day, no matter the root cause of high blood sugars or diabetes, a well-balanced diet that aligns with recommendations can only help and potentially even reduce the overall dose or need of certain medications. Again, diabetes is scary. Nobody wants it. Everyone wants to run away from it. But sometimes you feel like you have to make all of these really large, drastic changes to your diet, and that can end up actually making things worse, harder for yourself. If you're feeling like you have to have this quote-unquote perfect diet and it's not sustainable for you, then we're going to be back to square one anyway. So no drastic changes to diet need to happen right away. It's all over the course of time and just kind of, what do things look like for you? Oh, you want to incorporate more veggies for some extra fiber? Great. What would that look like for you? What resources do you have to do that? What does time look like? Do you have time to get fresh veggies and chop them up and clean them and cook them, do the dishes after, right? Those are all things that you can say, yeah, I'm gonna eat more veggies. Okay, how? What does that look like? And really walking them through that. And that takes time. We're not looking for quick fixes. Things like this typically don't happen overnight anyways. So allowing them that time and that space to talk things through with you, making sure things are actually realistic for them so that their outcome is nice and long and healthy and sustainable. But all of that being said, it's kind of like me on my podium, conclusions, takeaways. You can help by reducing that amount of misinformation, really helping people feel comfortable with understanding like this isn't an overnight thing that I need to do. Here are some places I can go. Remembering that people are already coming in very embarrassed a lot of times. So remembering that this could be a lack of understanding. We do a lot about stages of change in my job. So lack of understanding that pre-contemplation is essentially, yeah, okay, I've been told I have pre-diabetes, but whatever, or I've been told I have diabetes, they gave me this med. Okay, like the med's gonna take care of it. They just don't know. You don't know what you don't know. So they don't know the role that maybe some of their diet choices could be having in the outcomes of their labs. They just don't know those things. Limited resources or food insecurity, huge boundary. Go eat fresh fruits and veggies as they go, okay, and then leave and go, there's no way. That's not helpful. Now they just feel bad about that they don't have those resources and they don't know what to do. Like, it just totally didn't help anything at all. A complicated medical history or current medical issues that could be at play here, the fear, guilt, stress that's often associated. And then overall, that nutrition research is incredibly difficult to do. It's often very abstract, and it's often very generalized, and individualized care is like more specifically the role I play. So if you were to see patients and say, in general, go here for some good things that you can do, that's not going to hurt them. Then I could have the time to really sit down with them and be like, now what would these things actually look like for you? Kind of take it down to that individualized care side of things. Some references where I got my information, and then some questions. I wanted to make sure we had some time. Yeah.
Oh, okay, so some of the health insurances
Mm-hmm.
will pay for the pre-made meals. Aetna will pay for that.
Yes.
Have you found that effective?
So the question was essentially insurance and pre-made meals and what that kind of looks like if I found that to be helpful. So things like Meals on Wheels, Mom's Meals, goodness, there's another one I know I'm forgetting. What's that?
I'm sorry. Go
That's
ahead.
You're okay. Were you more talking about like Factor Meals, Home Chef?
Home Chef.
Yeah, I haven't had experience with that being covered. So, and it does. So that would be something to consider for sure, to let them know. When it comes to my role in particular, the insurance thing gets fuzzy from my experience because I work with patients who have primary care through Nebraska Medicine, so my service is completely free right now. We're looking to bill probably in the next decade or so, but they have also been saying that for the last decade or so. So we'll see, but right now it's all free, so a lot of times that's something that I might defer to social work and see what's compatible. Again, all working as part of a team, but that's really great. That's good to know.
Aetna will like help you. Part of the benefits is like the first 10 meals they'll cover.
Amazing. That's great. She said the first 10 meals they'll cover, anyone on Zoom. So that's a really great resource. Yeah.
I do med histories, and I was talking with a patient the other day, and I asked him, he's on atorvastatin, which is a statin for his cholesterol, why he decreased his dose. I asked him if the doctor did that or if he did it. And he said, well, I'm going to every other day because I read that statins can increase my blood sugars. Is that true?
So the question was, this patient was taking a statin. This seems louder than it did before. Okay. Someone was taking a statin. They reduced their own dose because they read that that could have had an impact on increasing their blood sugars at the higher dose of statin that they were taking. And if that's true. At the end of the day, maybe. Everybody's body's very different, but I don't like that trade-off necessarily, right? Like they're taking a statin for their cholesterol. If they feel like their blood sugars are going up, like it could be anything. Maybe you change your diet because you also read high cholesterol, and so now you're scared of saturated fats and you're eating less proteins because of it, and now you're having a higher carb diet than you were before. So there's a lot, it's so complex. It's usually never one thing. I'll tell you that. Like when it comes to nutrition, it's usually never one thing. Does that answer? Okay. Yeah.
Now, what do you think about like Weight Watchers or whatever Nutra thing it is?
Nutrisystem,
System,
Beachbody.
that type of thing.
Yeah.
Because usually, if you're on the system, it works for you for weight loss and that. But once you're off of it and you go back to eating like you've normally eaten before, completely throws everything off.
You're exactly right.
What do you think?
Yeah. So the question was, there's a lot of different diets, Weight Watchers, Nutrisystem, things like that, where it's essentially while you're doing it, people see success. The moment they stop, either they experience rebound weight gain or the success stops. What's my take on that, essentially? My thought is a lot of those are really great starting points for people. When it comes to like tracking your food, things like what Weight Watchers does, or MyFitnessPal, that very popular app to count calories and things like that. They're really great educational tools for people who are just like, I don't even know where to start. I don't know what calories are where. I don't know what's carbs, what's protein, because it helps to divide those things out. But yes, the accountability part of that can be helpful in terms of having Weight Watchers to log things into, or MyFitnessPal to log things into. And the moment you stop, it's almost like you tied the whole worth of what you're doing to that application. So it depends on the person. That's something we talk through a lot, is okay, do you feel ready to like kind of cut the ties, take things on your own and see if you feel like you've learned what you didn't know, that you feel like you can apply to something that's more balanced and everyday life-esque, if you will. And it might be a bit of a shell shock, but if you're working like with a dietitian or something, we can help kind of be like, what was the hard part? Well, I didn't realize that this had this in it and I would have seen that in the app. Okay, well now we know. Maybe we'll start with smaller portions or something like that. I really don't love the meals, like Nutrisystem, those kinds of things, only because they teach you nothing. They say, eat this at this time, in this amount, and call it a day, and you do that, and you lose weight, and then you stop, and you don't know what was doing that. You don't know why that was the effect. So you go back to cooking your own meals or hang out with friends and family, and you don't know, there's nothing changed. Does that make sense? So they're great tools. They're fine, especially for convenience. Those meals are great, but got to kind of think one step ahead. It's like, okay, well, why is this working? So that when I'm done, I can continue to do that for myself. Yeah.
So my question revolves around nutritionists. So do nutritionists assist RDs, kind of like how pharmacy techs assist pharmacists?
Wow, that's a really good question. Yeah. She's asking if nutritionists assist RDs kind of similarly to other technician type roles in healthcare. No. So a lot of major hospitals will have like diet technicians or dietary technicians, and they do deliver tube feeds throughout the hospital. They might do some like nutrition education for like heart failure, or if they're losing weight, they'll screen them. All the patients in the hospital in Nebraska medicine get screened, so if they're losing weight or they're not eating well, they'll go talk to them and be like, hey, what's going on? And then defer to a dietitian if needed. But no, not necessarily. I mean, diet tech is a good role for folks who would kind of want that nutritionist kind of role. But like, I could just be posting things on Instagram in my home for my job as a nutritionist. Like, I could work at GNC. I could, anywhere, really. Anywhere that wants anything health and wellness, a nutritionist could be.
Okay, so sorry.
No.
Follow-up question.
Yeah.
So if you personally wanted someone to assist you, you would look to the dietary technician?
Correct. Yep. And that's mainly on an inpatient role, not necessarily outpatient. Most private practices, Hy-Vee, those roles aren't there.
Any other questions? Wonderful. Thank you, Courtney.